Sir, thank you very much and good morning to all. So, as this is basically session of manual small incision cataract surgery, so most of the surgeons sitting here, they are well familiar with the technique of manual small incision cataract surgery. I think this technique, which should be learned by all ophthalmologists, it is very much helpful in many of the difficult situations. So we all know that age-related cataract is the commonest cause of uh, this cataract. So there are difficult situations which we encounter in our day-to-day surgical practice, and the most common in that is the hard cataract. The hard cataract, when we find that cataract is very hard, it is grade 4 Brownascent cataract, grade 5 cataract, then it is very difficult to operate with either phacoemulsification or even with simple manual small incision cataract surgery. And the second, which we routinely encounter, are the weak granules, which can be because of aging or which can be because of any other cause like trauma, old case of glaucoma, then in uveitic cataracts, like that. Then of course complicated cataracts or uveitic cataracts where the people is almost constricted, festooned people, and it is very difficult to manage either with phacoemulsification or with even manual small incision cataract surgery. In hypermature cataract, as our previous speaker highlighted that the access, capsular access is very difficult in hypermature cataract. So in those cases also manual small incision cataract surgery or phacoemulsification is little bit difficult. And of course zonodescence, pre-existing glaucoma patients, post-refractive surgery patients. So in post-refractive surgery patients, there is basically difficulty in the sclerocorneal tunnel formation. So we should be familiar. So when to enter in the clear cornea in refractive surgical cases. And also glaucoma operated patients, because in most of the glaucoma patients, the trabeculectomy, which we routinely do at 12 o'clock or the superior limbus, then there is a little space for the tunnel making in manual small incision cataract surgery. And of course vitrectomized eyes, where the eye is a little bit either soft and it is a little bit difficult to form the sclerocorneal tunnel. So these are the few situations where MSICS is little bit difficult, but it is very much helpful to give a very good results. So I am directly going to one of my complicated case, that is the hard brown cataract which with very big nucleus. So in this case, in these type of cases, I prefer to make little bit large outer incision, which is approximately 6.5 mm or sometime even 7 mm, because and my placement of incision is approximately 1.5 or even 2 mm behind the limbus. So that gives you good control of incision as well as astigmatism in most of the cases. So after making the scleral tunnel, before entering into the anterior chamber, I usually do capsular access from the side port only. So in these cases, the bigger capsular access is required because the nucleus size is little bit larger as compared to the grade 3 or grade 2 cataract. So you can say that with the side port, the nucleus, the capsular access is very easy. So bigger capsular access is required for easy expulsion of the nucleus from the back to the anterior chamber. And the inner incision, as our previous speaker highlighted, it should be approximately 1 to 1.5 mm more than the outer incision for the easy expression of the nucleus from anterior chamber to the uh, out, and good hydrodissection. After that, good rotation of the nucleus. So while rotating, it is very easy from the bigger capsular axis to expulse the nucleus into the anterior chamber. So you can see the size of the nucleus. So it is very big. So I usually prefer visco expression from the anterior chamber because it is very difficult to express out the nucleus, bigger nucleus with either irrigating vectors or with simple wire vectors. See the size and the texture of the nucleus. Now after that, it is very easy to implant intraocular lens. So one thing should be kept in mind that the incision should be larger for easy expulsion of the nucleus, and after that the closing of, because the nucleus is, the incision size is a little bit larger, so you can implant non-foldable or foldable lens of your choice. So it is very easy to implant even 6.5 mm lens through the bigger incision. So surgery take approximately 4 to 5 minutes in these type of cases. So one should master manual small incision cataract surgery to handle the challenging situations. This is the one situation. Otherwise, with a good sclerocorneal tunnel, with good incision, with good capsular access, with good control of the instruments, so you can overcome all the difficult situations that we routinely encounter in difficult cases. Thank you very much for your patience here.
Very well managed surgery in this is so big nucleus, but here what Dr. mentioned, inverted bat incisions will really help because you can reduce the incision by 0.5 or so, and with that number of this is SIA will be less. So our next speaker,
Thank
Dr.
you.